So, welcome back to the channel. I thought I'd start with a case series. And today we'll be talking about vestibular schwannoma, what it is, how we diagnose it, and the management. And then it this topic popped up for me because I saw a case yesterday and I thought it'd be good to just run through what a presentation could look like. So, there's a 22-year-old right-handed female who presents with some imbalance. She also describes that she's had some blackout episodes without loss of consciousness. It's been happening more frequently over the last few months. She said that before all of this, she's not had any medical history, no family history of any conditions that she's aware of. So you do a quick neurological exam and they tell you that she's got papilloedema in her eyes. She's got some decreased hearing on her right-hand side and complete hearing loss on the left. So here's the MRI scan. So they've done an MRI scan. Now, when you look at this image, it's most likely a T1 image, probably a non-contrast scan. You can see the nose here, back of the head here. You've got your ears on either side. The most thing that strikes out is a lesion. There's one here and one here. You can describe it as heterogeneous in nature as well. So it's got some mixed densities, perhaps a little bit of cystic component within it as well. It's round or oval in shape and with contrast it will generally enhance. You can see this sign called trumpeting. Looks a bit like a trumpet. It just shows that this tumor has extended into the internal acoustic canal. You can tell that, so on the scans, this is our right side and this is our left side, and the left side is much larger in nature, and you can measure it as well. This sort of fits with her symptoms being she had complete hearing loss on the left and sort of partial hearing loss on the right. It'd be useful to also do a CT scan just to see the bony anatomy as well. But MRI is really the best modality for these scans. So, in terms of vestibular schwannoma, what is it? So, vestibular schwannoma is a benign tumor of the cranial nerve. So, you've got cranial nerves 1 to 12. It arises from the seventh nerve, the vestibular cochlear nerve. So, you can see your ear, your inner ear, and you've got your semicircular ducts and cochlea, and this nerve here. So if we zoom up here, the schwannomas usually arise from the inferior portion of the vestibular nerve. And I guess in terms of symptoms, it can probably be described by some of the nerves that it impairs. So usually the clinical triad that we talk about is hearing loss. It usually starts on very gradually and it's usually progressive over time. Tinnitus, so ringing in the ears, usually high pitch in nature, and disequilibrium because of it's involving the nerve supplying the vestibular nerve, which is involved with balance. True vertigo is quite uncommon. It's one of the most common types of intracranial tumors, around 8 to 10%. And usually it slowly grows and becomes symptomatic, particularly after a certain size, usually at the age of 30. Now, 90% of these tumors are unilateral, so they're one-sided, but about 5% are bilateral. And when we see like here, there's two tumors, we always think whether there's a genetic predisposition to having these. So generally, they arise from a loss of a tumor suppression gene on the chromosome 22. And in most people, it's just a somatic mutation that occurs. But in a small percentage of people, they might have NF2, neurofibromatosis type 2. So this is usually an inherited or sometimes a new mutations, and they have a tendency to develop tumors. Usually bilateral is like a hallmark sign. Interestingly, they tend to form sort of grape-like clusters and that can infiltrate fibers, and they're more difficult to remove, and they have higher rates of cranial nerve deficits after surgery. When you put it under a microscope and have a look, they describe it as a tumor having composed of Antoni A fibers, which is sort of more densely, can you see it's more densely compacted, while Antoni B fibers are more spacious, loose reticulated cells. So these are all bipolar neural cells that are very narrow, they're stretched, and they're compacted, and they call them Antoni A fibers, and they're quite characteristic as well. Sometimes you can see cystic structures within the B as well. In terms of symptoms, you can see the most common symptom is hearing loss, and then followed by tinnitus, ringing in the ear, and disequilibrium. So other things like headaches, facial numbness, and when it involves other nerves, it's more uncommon. Very rarely do they ever block off the actual CSF system and cause something called hydrocephalus, that can be a neurosurgical emergency. Now, in terms of what studies and evaluations important, so we talked about MRI brain. We can usually get a Fiesta scan with it to give more details, especially about the cranial nerves as well. CT scan is very important in terms of bony landmarks, looking at the size of the canal itself, and then other audiometry testing. So you want to test their hearing, and it's really important to know how much hearing and what their deficits are in terms of planning for an operation, what approach you're going to be having. So pure tone audiometry testing, and speech tone threshold and speech discrimination scores are different types of audiometry testing. In terms of pure tone audiometry, it's a usual first step screening test, and assess functionality of hearing and sort of a baseline for surgery as well. Speech discrimination is usually maintained in sort of conducting hearing loss, um, and can be worse with sort of retrocochlear lesions as well. So all of these can sort of help with preoperative planning, usually getting brainstem audiometry evoked responses can also be good to establish as a baseline before an operation. So in terms of surgery, or in terms of managing vestibular schwannomas, the most important thing is to try to preserve the serviceable hearing as long as possible. If there's any compression of the brainstem as well, decompressing that from pressure. And then especially in the context for this patient where they may have a genetic abnormality, trying to counsel them, and they most likely may progress and have hearing loss in the future, and counseling them in terms of early lip reading, sign language techniques can be important as well in terms of considerations. Now, in terms of management, there are three main ways. There's conservative management, so usually just monitoring over a period of time, and you can usually do these when the tumors are quite small and they still have serviceable hearing. You can monitor them usually 6 monthly for 2 years, and if it's all very stable, you can progress to annual scans, and you can classify the growth rate as 2 mils per year as being slow, and rapid will be more than 10 millimeters per year. There's radiation therapy in the form of external beam, stereotactic, or gamma knife, and they're usually reserved for people who are not great operation candidates if they have two bilateral vestibular schwannomas. If after surgery they still have a residual left behind, or if the tumor still progresses. Or small tumors that have very good serviceable hearing and that you're worried about losing it through the form of surgery. Now, in terms of surgery, it is the mainstay of treatment, usually for large or medium-sized tumors. If there's brainstem compression, intractable disequilibrium, severe sort of cranial nerve involvement with trigeminal symptoms, or if there's blockage of the CSF system and causing hydrocephalus, then it'd be indicated. And then in the form of surgery, there's three main approaches that we can talk about. There's the mid, the first one is called the middle fossa approach in terms of trying to get that lesion. Second way is the translabyrinthine approach. And the third way is the suboccipital, or in this case, the retrosigmoid approach. They all have different indications in general, noting that the translabyrinthine approach will result in hearing loss. So it's an expected outcome of surgery, and it's usually for patients that have very poor hearing on that side already. The good thing about B, though, is that it's a lot less risky for being worried about the facial nerve and injuring that during surgery. And C would be the retrosigmoid, and it has better hearing preservation. And usually the middle fossa approach is usually reserved for far lateral tumors. So that's a basic overview of vestibular schwannomas. Let me know in the comments on what next topic you'd be interested in listening to. But otherwise, stay tuned for the next one.